Hi, it's a special pleasure to have an opportunity to speak with you in this important newborn screening research summit. My work contributes towards the progress of rare disease research in detecting the etiology of genes involved in heritable disorders of deafness and hard of hearing, which we sometimes abbreviate as DHH, in newborns, exploring gene therapies to improve DHH across the lifespan, and discovering mechanisms of genetic hearing and deafness to expand our knowledge of human biology. In addition, my work contributes to understanding genomic sequencing as a pilot analysis at this point for newborn hearing screening to facilitate early habilitation, cultivating appreciation of acoustic trauma, necessitating hearing protection, and maybe this is important for your teenagers, and being an advocate for congenital CMV screening in newborns to reduce preventable and treatable hearing loss. So during this presentation, I'm going to start with a background of hearing as a component of newborn screening. In this section, we'll talk about the prevalence of deafness as a profoundly genetically heterogeneous lifespan disorder and the impact of prenatal screening now that's having for various panels of genes that include genes for deafness. I'll review with you our experience with genomic sequencing for genetic etiologies in a project that we fondly refer to as SEQaBOO, which stands for Sequencing a Baby for an Optimal Outcome, and then share with you the interpretation of structural variants, which reveal new knowledge that can be burdensome and also beneficial for families. So we'll discuss compound genetic etiologies, which include single nucleotide variants and structural variants, and implications for future pregnancies. So here you see an incidence of congenital disorders detected through routine newborn screening that was performed by a group in California between July 2005 and July 2010. And there were over 2 million newborns screened. And I think you can easily see that there's a really large number of deaf cases among this group that is 5 times more than the next most common disorder, which is congenital hypothyroidism. The etiologies of congenital deafness are defined here. The frequency in newborns and children in the US is about 3 in 1,000 newborns who have permanent hearing loss. 1 in 2 of those cases are in babies due to genetic causes. 1 in 4 are in babies due to maternal infections during pregnancy, complications after birth, and head trauma. And the increase in cases in children by school age includes those with mild or unilateral hearing loss that are not necessarily detectable by the automated types of hearing loss screens that are done in the birth hospital. About 10% of newborns with asymptomatic congenital CMV infection present with hearing loss at birth as their only symptoms. And PCR of blood spots has a sensitivity of only about 28%. 18 US states have effectively passed legislation requiring congenital CMV testing, and states which have not actually passed legislations may have what we call hearing-informed congenital CMV testing. So if a baby who is screened does not pass their newborn hearing screening test, then they will go ahead and send a test for congenital CMV. So you can see there's a large genetic component, and then there's this component of CMV, which is not minimal. So it's something that is really valuable in terms of thinking about prevention and also treatment of these types of infections. So hearing loss is a genetically heterogeneous disorder with a current estimate of greater than 1,200 genes for hearing. When we think about the genetics of deafness, about 30% are syndromic, meaning they have another abnormality that's potentially useful in a diagnostic way, and 70% are non-syndromic. So these are all cases in which there wouldn't likely be any type of clinical finding that would be useful to categorize the disorder. With regard to the inheritance, 80% are recessive, 19% dominant, and less than 1% mitochondrial microRNA and X-linked in origin. And about greater than 8,100 known pathogenic or likely pathogenic variants have been described, and this is, of course, increasing, especially with the fact that we are estimating now 1,200 genes for involvement in hearing. So I had the opportunity a number of years ago now with my chairman in graduate school, Dr. Walter Nance, to write a paper that was published in the New England Journal of Medicine. And one thing that was not well known to us at that point was what the difference was in terms of the number of cases with permanent childhood hearing loss at birth as compared to, again, another child by age 4 who would have also have a hearing loss. And it was pointed out to me by a genetic counselor in Ottawa that what these two circles have told us is that if we were able to actually add GJB2 testing and CMV testing, that we would be able to actually add quite a bit of a diagnostic ability in the newborn period for kids who would potentially develop a permanent childhood hearing loss. So that actually also was very important in talking with the folks in Ottawa and to Marie Pigeon, that by doing blood spots for hearing loss, that they were not missing any kids potentially during the pandemic, because they had them also included in the blood spot analysis. So this is the audiogram of a newborn who I like to think of as what we're living in Generation Genome. We're all living in Generation Genome. So this baby underwent an initial auditory brainstem response evaluation during natural sleep when he was about 7 weeks old. So it turns out that the parents had prenatal screening during the pregnancy and learned from that there was, each one of them harbored a variant in GJB2. A different variant, but each one harbored a variant, and then they were at risk to have a child who would inherit both of those variants and have a hearing loss. So what you see in this audiogram is that on the right ear, the hearing was fine out to 8 kilohertz, but the left ear at 7 weeks actually had already shown loss of audibility. And then a subsequent audiogram in the left and right ear shows you that both ears had increased thresholds at 20 weeks. So I feel that this is something that has sort of a silver lining, if you will, because this tells us that some cases who are GJB hearing or connexin 26, that's the protein, have that etiology, may actually be able to be to receive a gene therapy that could be helpful when that time might come to be. So this is I think something that we'll see increasingly as prenatal screening continues during pregnancy, and where various variants for hearing loss are detected. So there's nothing but anything but love for newborn hearing screening. But there are some downsides to the physiological screening, either automated audiometry or otoacoustic emissions. So neither one of these tests actually detects mild or delayed hearing loss. Neither one can distinguish temporary from permanent hearing loss. They do not identify risk for ototoxicity. And what I mean by this is whether they have a variant that might cause them to be susceptible to ototoxicity, a genetic variant. This does not identify the etiology of the hearing loss, and there's a high false positive rate, which is something that we find ourselves in the position of telling parents that although their baby has not passed this test, there's a very good chance, like 80%, that the baby will pass the diagnostic audiometry that will occur in 4 to 6 weeks after the referral to a facility that will do a diagnostic test. Okay, so newborn hearing screening was rapidly implemented. And why is that? Well, it's because precise diagnosis impacts care and management. So it's clear, for example, that if your gene that's underlying your hearing loss is one of those in the first group here, GJB2, SLC26A4, MYH9, or MYO15A, they appear to benefit from cochlear implantation. So that would be a conversation that might occur earlier than later if a genetic etiology was known. Some genes actually may do more harm than good from amplification, and that's an important fact in terms of trying to improve the audibility of a child's hearing. Then a gene like the mitochondrial gene that provides or results in sensitivity to aminoglycoside antibiotics is something that you would like to know early as possible, so that if the child were to be put into the NICU, that an antibiotic other than the aminoglycosides antibiotics would be chosen. So maybe there are others debilitation, and perhaps future cochlear implant decisions will be guided by genetic testing. Or is there a future for a genetic prescription for a hearing device? So you can see various types of hearing aids that are possible, as well as even those AirPods Pro, which are pictured at the right of the slide. The other thing that's really important for us to think about is that syndromic disorders can be indistinguishable from non-syndromic disorders at birth, but obviously the genetics would make that known. And you can see a list of different genetic etiologies of hearing loss that do have other findings, but are not present at delivery or in the newborn period. So it's important, if we just pick one of them, to know that the underlying disorder is Usher syndrome, and that portends actually a risk for blindness. It's the most common deaf blindness syndrome, but that wouldn't necessarily make itself known at an early age, and you would potentially like to choose habilitation that doesn't involve sign language, because in this respect, if your child were to lose their vision, then the sign language would not have been an optimal choice. So what about genome sequencing for deafness? So genome sequencing technologies can detect genetic variants across the hierarchy of mutations. So from aneuploidies, structural rearrangements, and copy number variants to single nucleotide variants, which we are familiar with. So in a study of greater than 8,000 newborns admitted to the NICU, show that genetic diagnoses were associated with a 15.6% increase in cases of diagnosed hearing loss that were not detected by newborn hearing screening. So this is exactly like the case that I showed you with living in Generation Genome, where the baby had 2 variants for GJB2, which then became known from other diagnostic testing later on. But this was a baby who passed their newborn hearing screening. So we don't want to miss those kids that sort of fall into a gap between having a normal newborn hearing screening result, but then later on go on to develop hearing loss at a time when neither the parents nor the pediatrician would have suspected that that was an etiology for any type of speech and language delay that the child was having. And then the United Kingdom 100,000 Genomes Project pilot data revealed a diagnostic rate of 46.3% in 54 cases with congenital hearing impairment. So this is actually validating its utility at that time. And then while performed mostly on a research basis, genome sequencing has expanded the practitioner's utilization of genetic information. And to this end, several years ago in 2019, a group of us met at the American College of Medical Genetics office and looked at the way the current newborn hearing screening worked and compared that to what we thought a proposed comprehensive newborn hearing screening could do. So all newborns, again, are getting physiologic screening, and when they fail the newborn screening test, they would then go on for genetic testing, CMV testing, and other evaluations. The proposed comprehensive screen would bring all of these things together: the physiologic screening, because there are some etiologies of hearing and deafness that are not genetic, so you want to still have the physiologic screening, genetic testing for the reasons I've just discussed, and congenital CMV screening. So this will, by changing this to a proposed comprehensive NBS screen and testing, will provide the etiologic information, will importantly reduce the time to diagnosis, because it's often not a timely bit of information that comes by the time the genetic testing results are available to the family. And it would be valuable to reduce the time to habilitation for the child. And then in the US, we do have a country of 50 countries, and there are variants in the states as to how the referrals to follow-up are managed. And in some states, there's as much as around 50–60% of loss to follow-up for families that need to have a diagnostic screen taken, whereas in other states, it's more coordinated, and there's quite a good rate of like around 93% or so to follow up so that they get a true diagnostic test. So I want to just describe for you quickly about the project that we have just finished closing, the NIH grant. We enrolled families in SEQaBOO at 3 Boston hospitals, and then planned also to enroll them at a hospital in Texas that sits very close to the Mexican border. So here in Boston, we were actually meeting families whose baby did not pass newborn hearing screening, and approached them to enroll before leaving the hospital. And then at Boston Children's Hospital and Massachusetts Eye and Ear, we invited otherwise well newborns that were born at other hospitals who do not pass newborn hearing screening and go to either Boston Children's or Mass Eye and Ear for diagnostic audiology. And then the family was approached at audiology or at the otologist appointment before the age of 6 months. And then we had this wonderful plan to increase our diverse population by enrolling families from Doctors Hospital at Renaissance. And these were otherwise well newborns, 98% Hispanic ethnicity, confirmed as well to be deaf or hard of hearing. And they opened the enrollment in the summer of 2022, but no enrollments took place before the study was closed. So at least there is an appetite for being able to screen the babies for hearing loss, but it just did for genetic hearing loss, but just did not happen at this time. And of course, this study was run during COVID. So as you can imagine, there were a number of complexities in working through all the enrollments. So this is what it looks like if there's a trio. You have mom and baby, and most of the times dads. We offer them for sequencing genomes and analyze 108 established hearing loss genes. We report the results to the otologist, and if the result is positive for hearing loss, and the otologist then orders confirmatory clinical diagnostic DNA test. And then if it's negative, then it's either confirmed to be hearing loss or no hearing loss. Without hearing loss is reported to the parents, and then if it's confirmed, and we analyze a larger set of hearing loss candidate genes, and if that's negative, then we analyze a genome for novel gene discovery project. So we use 30x whole genome sequencing to detect the single nucleotide variants and small insertions and deletions in deafness genes. We also started to add causative we also tested causative single nucleotide variants and indels, and these were found in 6 babies who were confirmed to be deafness, out of a total of 31 individuals from the audiologic testing who were confirmed to be deaf. There were 13 babies that had inconclusive findings, and those were ones where one pathogenic variant or a VUS detected in an autosomal recessive gene were identified by the sequencing. And then we went on for a further analysis of the genome sequencing data to investigate the contribution of structural variants. And that's my large message today, is to talk to you about what we've learned from that particular approach to increase our yield of true positives. So you're all familiar, I imagine, with the routine of genome sequencing, where the DNA is fragmented, made into a library, and then the reads are aligned to reference genome, and then we identify and interpret the mutations. Here's a summary of our enrollments. We enrolled from July of 2018 and to June 2022. And our COVID research, clinical research, was shut down in March to October of 2020. We were really delighted with the enrollment rate. 76% of families approached enrolled in SEQaBOO, and you can see the distribution is for participation in our survey only about genomic sequencing and the parents' opinions on that. Then also they could elect to have genome sequencing of hearing genes only, and that was another 20 individuals. And then genome sequencing of hearing genes plus for the parents only, not for the newborn. We would offer to interpret the ACMG secondary findings list, and that actually started out with ACMG 59, and we ended up interpreting the secondary findings for the version 3.0. So you can see the summary of cases for hearing. In the solved hearing loss cases were 6 cases, and that means that only pathogenic or likely pathogenic variants were acceptable for based on the ACMG guidelines. And then there were 12 inconclusive, and inconclusive included 1 pathogenic or likely pathogenic variant in a recessive gene or variant of uncertain significance in a dominant hearing loss gene, or negative, where there were negative cases represented those with a known non-genetic cause of hearing loss, such as congenital CMV infection or a demonstrated brain malformation. And then the remainder actually were past their audiology follow-up, and we had a few there that were also inconclusive, but the majority were negative. So our addition of analysis of the genomic structural variants would allow us to detect duplications and deletions larger than those that would be picked up in the single nucleotide variant analysis. So these are well known as copy number variants. And then also we were interested in detecting structural rearrangements. So this could be a large insertion. So that was something that maybe would have been picked up on a cytogenetic analysis had one been done, and as well as translocation. So many visible cytogenetic rearrangements. And we were able to work with a wonderful colleague, Dr. Elvis Dong at the Chinese University of Hong Kong. And we detected these in a method called read depth-based approach. And that would just show you that we would normalize the amount of reads in bins along the genome and then compare them, this normalized analysis, to the reference genome. And then if there was a chromosome variant, like a translocation, the read pairs would align to the reference sequence, and they would often show a pattern of soft clipping the reads, which would achieve nucleotide level breakpoints. So the discordant read pair analysis actually will detect these structural variants. In addition, and in collaboration also with Dr. Matthew Chow, who is an LGG fellow at Baylor at this time, we also were able to detect the absence of heterozygosity. So you could see this by the SNP arrays or by genome sequence-based absence of heterozygosity detection. And you look in these regions that actually are aligned with what we would see in the SNP array, but you can see that there's a loss, an absence of heterozygosity greater than 5 megabases. So you can see what this example of a genome sequence-based detection of the absence of heterozygosity would appear. So we were somewhat surprised, I think, to find as many cases when we reanalyzed their sequence analysis after we had this opportunity to evaluate the structural variants and absence of heterozygosity. So we reanalyzed 90 trio/duos. And what you can see is the first 4 cases are not surprising, that stereopsilin is a gene that is often deleted. And we found 4 cases in which there was a heterozygous deletion in the mother. And then we had a case where both parents had a deletion in stereopsilin, and that was accompanied with a deletion in CATSPR2. And that area of a deletion actually is a risk factor for in the setting of a homozygous deletion of deafness and a disorder known as deafness and male infertility. And it's very memorable for me that we had a couple who we needed to provide that potential risk for them, and they had actually accommodated over time the fact that their son was not hearing, but the fact that this was like a second blow for them, and this was really a tough experience. Then there was another deletion. This was a deletion in otoankyrin, and then one very surprising finding for me as a clinical cytogeneticist was the finding of 2 balanced rearrangements. So case 1, the very first case we enrolled in SEQaBOO, turned out to have an 1822 apparently balanced rearrangement, and case 58 had a 621 apparently balanced rearrangement. So this sort of stumped us for a bit in terms of how we should handle this, and we ended up going back to our IRB and asking for their permission to provide this information, which is an incidental finding, to the couple. And they actually turned back to us and said, well, you are the experts in cytogenetics, so we would leave this determination to you as to whether or not to provide that information to the family. And it turns out that both of these cases were the individuals had IVF and were both knowledgeable of the fact that one of the partners carried the rearrangement, and they did not have any type of confirmatory testing on the embryo and did not know that in both cases those babies had inherited the rearrangement. So this was a somewhat lengthy disclosure session for them, for their babies, but I think that this was a valuable piece of information in terms of what they might want to share with their child as they are old enough to handle this type of information and think about having their own families. We found one with an XYY, and then there were 2 cases which had absence of heterozygosity on at a couple of sites, and this was also determined to be an incidental finding for those families. And this information was not actually disclosed to those families. So let's just look at the stereopsilin deletion. This was a case, newborn male, failed newborn hearing screening, had subsequent diagnostic audiometry, and that gave a result of bilateral mild sensorineural deafness. And there was no diagnostic pathogenic or likely pathogenic single nucleotide variant, but it was in combination with a VUS. And here's the VUS in stereopsilin. So this is showing you, well, let's look here first. Here's the read depth analysis, and you can see clearly this region in which the deletion, which was a maternal deletion, was located, and that this was an 83.3 kb deletion of stereopsilin and caspr2. You can see right here is a diagram of what that area looks like in the genome. So there's a lot of repetitive area here in terms of the genes and pseudogenes. So here's stereopsilin and a pseudogene for stereopsilin, and caspr2 and the pseudogene for caspr2. So this area often undergoes some type of recombination and deletion. So that is the etiology of loss of stereopsilin, and also in some cases, homozygous loss of function variants of stereopsilin and caspr2 associated with deafness and male infertility. Here's another stereopsilin deletion we found. Both parents had a heterozygous deletion. We did not find a homozygous deletion in the baby, and we don't know which parent actually contributed the heterozygous deletion. But this was also a large deletion of 93 kb of stereopsilin and caspr2, and there was some important information for them in that their offspring would have a quarter risk for homozygous deletion of both stereopsilin and caspr, and then that would be associated with deafness and male infertility. For otoanchorin, again, another deletion. There was a newborn male, failed newborn hearing screening and diagnostic audiometry, and there was no diagnostic pathogenic or likely pathogenic SNV. You can see here the region of the deletion, which was a 16, I'm sorry, right here was a 16, chromosome 16 in the short arm, maternal etiology, and a whole gene deletion of otoanchorin. So the combination here was actually a VUS that was paternally inherited. So there was just an otoanchorin deletion and a VUS that was paternally inherited, which we would predict that at some point this will be determined to be a likely pathogenic or pathogenic variant. So this is again, otoanchorin biallelic loss of function mutations and etiologic for non-syndromic deafness. Now I'll show you quickly those two translocations. Here was a 621 translocation. This was a female newborn with mild bilateral mild to moderate deafness, and the father also has deafness. And in the conversation with the father, he told me that he thought his hearing got worse after the military service that he had done. And of course, he wasn't able to give us any type of idea of how deaf or how hearing impaired he was prior to the military. But we found that this actually disrupted a gene on chromosome 6 called CDK19, but that gene was unknown to cause hearing loss. And you can see what the rearrangement looks like. Here's the derivative 6 going into the sequence on 21, and here's the derivative 21 going into the sequence of chromosome 6. There was a little bit of noise at the breakpoint, but still basically largely balanced. And you can see here that there were breakpoint specific PCRs performed that showed us that the father, here's the father, and the baby had the similar breakpoint PCRs done, and you can see here again the father and the baby, the proban. And here's the other case, case 1, the 1821. This family was not able to, we were not able to speak with them, although we had offered several times on their cell phones for a chat with us. But their baby passed diagnostic audiometry, and we feel that even in the very beginning they passed, and they were not they were busy and wanted to go on with having a normal hearing baby, and didn't want to perhaps go further into this with us. But you can see that this is a really a pretty balanced rearrangement. The breakpoint on chromosome 18 disrupts a gene called DYM. It's loss of function mutations cause 2 autosomal recessive conditions, which is not anything that was observed in this baby. And the breakpoint on chromosome 22 disrupts a gene PHF21B, and that was not known to be disease associated. And lastly, I'll just show you sort of what the output looks like for looking at the absence of heterozygosity. So you can see here's an AB distribution on chromosome 6. And then and this is on the long arm of chromosome 6. And then one on the short arm of chromosome 11 here, get picked up here in this particular analysis of the AB allele distribution. So in summary, the knowledge of a secondary finding not revealed for newborns in SEQaBOO, because we did not interpret secondary findings for newborns so that they would have the opportunity to make that decision for themselves and have an open future. So this can result in the burden of an unanticipated finding in the parents. And we did have 4 secondary findings that were identified in the study. And one was in call 3A1, and one was in Titan, and these were pathogenic variants. And these are the 2 that the individuals wanted to pursue a conversation about. And the burden is not only for the patient, but also for the healthcare providers' patient management, because generally the healthcare person, at least from our experience, was not informed of this type of analysis, and also they didn't know anything about the genes that were identified to have variants. So it does lead to the benefit of potential decisions that might also save a life. And I think these are the words that actually made this somewhat okay for me to think about what consequences there might be. And then the interpretation of structural variance and absence of heterozygosity in SEQaBOO can uncover the burden of an incidental finding in the family. So a chromosomal variant that they didn't know about, or the risk for a Mendelian disorder that maybe underlies an absence of heterozygosity. And this can then, the unassociated target of the initial testing was not for these genes, and it can lead to the benefit of future informed prenatal testing, preventive management, or potential discovery of genes yet to be involved in hearing. So in summary, I just want to drive home the fact that genetic screening does not replace newborn physiologic hearing screening due to non-genetic etiologies that we don't want to miss. Genetic screening identifies high-risk newborns not detected by hearing screening. So like our baby who was living in generation genome was a high-risk newborn and deserved to be followed for potential habilitation. Population screening of a limited number of common pathogenic alleles is feasible and effective, and we used the cord bloods from the babies for obtaining the blood samples. Genome sequencing is likely to be the primary method for screening within the next few decades. I think is a pretty large window, but I would be very happy to see it happen sooner than that. And of course, gene therapy, and there are many that are in development now, requires knowledge of the genetic etiology. So this basically, took a village. Many people at Brigham and Women's Hospital who were involved over the years, especially my colleague Ann Giersch, and various really wonderful program managers, Yvonne Chekaluk and Callie Mitchell, and now I can't find Abby Lorenzo, and then physicians in the Brigham Genomic Medicine who helped us with our secondary findings, and then the audiologists and newborn medicine folks who were involved, and then our colleagues at Boston Children's Hospital, Harvard Medical School, and Harvard University, and Mass Ioneer, and Mass General for the Laboratory of Molecular Medicine, and the sequencing at the Broad Institute, and then my colleagues at the Manchester Center for Audiology and Deafness, who were very instrumental in talking to me about the possibility of doing the genomic sequencing for the diagnosis of genetic etiologies. And of course, thanks to the NIDCD, the Nesky Family Foundation, and to Brigham and Women's Hospital for supporting this study. Now, I'd be happy to take any questions you might have.